I wanted to welcome everybody to the very first Mondays in March for this year. Mondays in March really started as a way to continue to increase and enhance communication about what's going on across the university. What are those key things that we are doing? What are those key things that we're responding to? And it's also a way to hear what is on each of your minds as we continue to evolve and grow. We're doing a little bit something this year based on the feedback that we've gotten from a lot of different people. We're really going to be having panel sessions this particular time. So each week we're going to have a panel discussion around a key strategic event or a key strategic initiative that's very important for the university and where we're going. And it's also centered around many of the questions that we have gotten from many of you and throughout the entire university. So we've named this series, it's Mission Critical, Conversations on the Future of Improving Health. The panel discussion today is going to focus on the case for growth. Next week, led by Ms. Donna Sollenberger, we're going to talk about the evolution or the revolution of healthcare. The week after, we will be focusing on the academic foundation. And then the last week is really just going to be a panel discussions of Q&As that have come up over the course of the 3 weeks. We'll help to be able to reiterate any points and to respond to questions that you may end up submitting online. Before we get to the introductions, I would be remiss to say Stat Madness has begun. So I don't know, so we all know March Madness. In the last couple of years, we've had Stat Madness. Stat is an online medical and scientific journal that's actually pretty well respected. And each year, they go through and they choose some of the top research articles that have actually come out. And then you have to go in and vote for those every week, just as if you had your March Madness bracket. UTMB is on the brackets again. So this year we've got the lungs in the lab. And so I encourage you to go out and vote. If you go to IUTMB, there's a link out there. Vote often. You can vote multiple times. Each vote each week ends on Thursday. And so keep watching as we go. And every single vote matters. We were sitting in our department meeting this morning. We were 8 votes behind in the lead. And all of a sudden, it's funny, we were all of a sudden about 3 or 4 up. So every vote matters. Every vote matters. All right. So with that, I want to introduce the panel for this morning. I think everybody knows Dr. David Callender, president of UTMB, will be moderating the session today. Cheryl Sadro is our Chief Financial Officer. Dr. Vicente Resto has multiple hats, but today he's going to be here as our Physician Executive for Growth and Associate Chief Physician Executive for the Faculty Group Practice, and then Becky Korenek, which is our Senior Vice President for Strategy and Business Development. With that, Dr. Callender, take it away.
Thank you, Steve. We're up against Penn for Stat Madness, right? Yeah, so first round, and as you know, the more we vote, the more likely that we progress our team, and we want to get them into the Final Four. This is the project, remember, that Dr. Nichols and Dr. Cordiella did, really focused on an opportunity to create tissues for infectious diseases research. But what they've ended up doing is growing lungs that could be functional. I think the most recent advance is that the circulatory system of these lungs grown in the lab actually connected to the native circulatory system in the pig, which has never been done before. So the significance of this, obviously, is if you can make that happen, then there is potentially a path then to connect the major airways and actually have the lungs function. Whatever Penn has out there can't possibly be as good or as exciting as that. So get out there and vote. But I digress. And I was thinking about maybe doing something fun with this. Appreciate all of you who have braved the cold to be here in the auditorium today. For those of you tuning in, you're a bunch of chickens. We'd rather have you here, but it's okay. We'll let you pass since the temperature's in the 40s. But maybe, and obviously we've got our experts in terms of growth, and you all have heard me talk about growth and why we're doing it, why we think it's important, why we want to position ourselves for growth. We want to dive into that today. And this is the unscripted part. So I'm going to pick on a few people I know. So Ojo, walk up to that microphone. And he's a good sport. I know he'll do this. And then Dr. Raymer's next, and then Mr. Heilman, because I see them out there. So, Ojo, why is it important for us to grow from your perspective on the organization? You're helping lead CMC. Obviously, there's a lot to do just with that confined, literally and figuratively, patient population. But in terms of the university, what are you seeing that you think might lead us towards wanting to be bigger or geographically bigger?
Excellent question. And I've been at UTMB since 2001 as faculty. And I remember my first initial years, it was always, we will mouth off, we need to expand, and we never did anything about it. And then Ike happened, and we had no choice, because the population on the island is fixed. And if that's what UTMB was going to be known, we were going to go down. And so some guy came along, Callender, and this growth just happened. I mean, I live on the mainland in Lake City, and it's amazing to me what we are doing on the mainland, off the island. So that's another point where we have to do it. But the other point is, reimbursements are down, all right? NHI grants are down. And so you have to do things differently. We, as UTMB, have to do things differently. We got to find those emerging markets and tap into it. All right? And we're not just the only academic medical center who's wanting to do this. Everybody wants to do it. We're all facing the same challenges. And so whoever is able to tap into those resources, be innovative, is who's going to be left standing. So this is, I like that topic actually, mission critical. And getting the strategies right for growth is a do or die. It's a dog-eat-dog world out there. And we have to do it.
All right. How about a hand for Dr. Ojo? Okay, Dr. Raymer, what about from your perspective? Is growth important, and if so, why? And if not, why?
I think growth is critical for a number of reasons. First, growth allows us to some extent, control our own destiny. We have to have a market share that supports our primary mission, and that is our student education and residency education. And people aren't just coming by and giving those residency slots away. We have to position ourselves with a number of beds in our health system that will be attractive for our educational mission and also attractive to partners that we may choose to partner with. No one usually wants to partner with someone who has an inferior position in the market. But if you've got a large piece of the market and can bring something to the table, it makes it a lot easier for our contracting team, Becky, I think, to go out and get those contracts. That's the economic engine that drives our entire university. If we succeed at that, we will certainly succeed in a critical mission for the longevity and the success of UTMB.
Thank you, Dr. Raymer. Outstanding. So one, as he says, thinking about just the need for clinical placement sites. Texas needs more physicians, more nurses, more health professionals, more PhD scientists, focusing on health-related problems. We are going to be asked, we continue to be asked, and this will be the case well into the future, to grow our enrollments in response to the need around the state. So having more sites, more places that can accommodate our trainees, no matter whether they're in the medical school, nursing school, School of Health Professions, or graduate school, is going to be important for us if we're going to be able to continue all aspects of our mission work. He also talked about partnerships. As we think about how we best go forward, we're thinking about horizontal integration, if you will, and vertical integration. So horizontal in terms of thinking about partners like us that would help us expand geographically, vertical integration, expanding beyond what we do today, particularly in healthcare, so we can create a value chain through the various forms of healthcare that's most efficient and allows us to optimize the return on investment. So all of those things are important. Dr. Raymer, thank you for throwing all those out there, and thank you again for your comments. Okay, Mr. Heilman, your turn. And you're helping guide the biggest department on the campus. You've got a lot invested in education and research and clinical care. So from your perspective, is growth important?
Absolutely. First and foremost, I think the missions Dr. Raymer brought up are truly important. And as we look forward and combining some of your comments, Dr. Callender, about growth and associating with other players in the market, as we move towards that population health management model, a little bit away from the fee-for-service model, those associations and who we bring into the fold in terms of our community partners, physicians out in the community, to help bring our covered lives up to a certain point where we do become a major player in the market. We're not susceptible to being locked out to certain contracts because we don't have enough population. So for me, it's growth is extraordinarily important. When I came here in 2007, that's what I was looking forward to. And obviously we had a little hiccups on the way. But what we've done over the last, call it 10 years since Hurricane, is absolutely amazing. And some of the clinic locations we have now, the expansion of Lake City, the acquisition of what was Bay Area, now Clear Lake campus, is going to set that stage moving forward. I think we're at a pivotal point, an inflection point, if you will. What we do today is going to set the stage for the next 20 years. So I believe that growth is very important as we move forward.
Great. Thank you very much. I don't think we have to say anything.
No, we're
Everything's
done
pretty well
speaking. They
covered.
pretty
Yeah,
did
thank
it,
you
yeah.
guys. Thank you all very much. So what we want to do, though, is to sort of dive into some of these details now and talk a little bit more about what's happening out there in the marketplace, what's happening financially. You all have heard me say, well, the revenue per unit of service in each of our mission areas is shrinking. So for every unit of clinical service, if it's measured by RVUs, we typically look at the productivity of our physicians by RVUs. Well, in general, the reimbursement rate per RVU is less today than what it was a few years ago. And we think that trend will continue. It will go down over the course of time. So that tells us, number one, to sustain revenue, we have to have higher levels of productivity. And then if you think about the opportunity to increase revenue, we have to become more efficient. So the amount of effort that's necessary to provide that RVU of care is actually less overall. The process is more effective and efficient as we go forward. And so we're thinking about that too, to make sure that we get adequate numbers of patients means that we have to have the right sorts of contracts going forward. And we're thinking about how we do that. On our own, it may be less possible or perhaps even impossible to have appropriate contracts that send us enough patients. Ms. Sadro is certainly an expert in this area. She's spent years in her career. Well, I don't want to say that the wrong way.
It's okay.
Sorry.
I was 2 when I started.
A lot of time thinking about these issues from the standpoint of different healthcare organizations. So when you look at that, look out there today and think about UTMB and where we stand today, and when people ask you, when you go around and talk to people, what do you say are the principal reasons that we should consider growing into the future?
Sure. So as everyone has said, and David and Ben and Ojo did a beautiful job, we really have seen reimbursement change. So as it begins to change, we have to change with that. So what does that mean? So everybody knows we get a lot of Medicare and Medicaid, and we have had not as much commercial in the past, but due to some efforts with Becky and her hard work, and now Monica, we really are out there looking at how we can increase that reimbursement. Part of it is growth. We need a little bit more commercial business than we have today. And so that's part of getting off the island and getting to the mainland and getting close to those patients. The other thing you hear so much about now is value-based reimbursement. Well, what does that mean? Well, there's a value base that we're all marching toward, and there's a volume where we've been. So we used to get paid for every patient we saw, or every patient in the hospital, or that came into our clinics. And now payers, Medicare, Medicaid, and the commercial payers are really beginning to say, hey, wait a minute, if I pay you by, forgive me, widget, then that means maybe I'm incentivizing you the wrong way. So now people pay us by how well we take care of our patients, which we have done a really good job of here at UTMB, and how we control our costs. So we're looking now at different ways to enter into those agreements. Donna and her team did some experimentation with a bundled payment, meaning that a payer would pay us for one type or one payment for an episode of care. So from the time the patient begins to get some treatment to the end of the treatment, whether that be outpatient or inpatient, we got one amount. And that's a good thing because that allows the payers, I guess it's a good thing, Medicare, to understand what they're going to pay us. But for us, it really does require, and when I say us, I mean all academic medical centers, all healthcare entities, it really causes us to step back and say, okay, how can we take the best care of our patients, because that's really what's at the forefront of this, but be efficient and effective for the payers. You remember, a payer's cost is what they pay us. They don't buy the supplies, they don't hire the doctors generally, and so forth. So their cost is what they pay us. So they're looking for us to be as efficient as we can be. Reimbursement's not going to go up under that scenario. Reimbursement's going to continue to go down under that scenario. There are other ways. There are accountable care organizations. You've all heard about those. And what we look at right now really are some of those things, but we also look at direct commercial payer contracting. So Monica's working now a lot on those. Payers, and what does that mean? Payers will ask us to do certain things for populations of payments. We like to call them attributed lives, how we look at a whole body of patients. And they will pay us for certain health indicators. I'll keep it that general. And if we do these certain things and keep patients healthier, we might get paid a bonus for doing that. That's called upside risk. And with every bit of gravity, there's the downside too, right? So if we don't do that, payers now are coming back and saying, hey, wait a minute, you didn't meet these metrics. We don't think you were as cost effective as you could be, so maybe now you need to pay us back. So all of these initiatives are still getting started. There's a lot of data out there that says that these types of payment arrangements have increased 2- and 3-fold over the last 5 years. They're going to continue. At one point in time, we used to say, well, wait a minute, we've got both feet, one foot in one canoe and one foot in another canoe, meaning we're paid the old way and we're paid the new way. Well, the foot over here is getting a little bit heavier, and it's becoming more and more that pay for value that payers are looking to us. And it's all very doable, but it's change, and it's constant change. It's not something that's going to stay the same like it used to be when we, way back in the day, before I ever started, before I was 2, way back in the day when we were paid just the cost that it took to take care of somebody. That's going to change. And I'll add this on, so I want to tell everybody thank you for all the work you've done this year, because you really have come around and just continue to do beautiful work. As our reimbursement decreases, our expenses don't. We still have to pay suppliers at a slightly inflated rate, salaries at a slightly inflated rate. And if we're going down over here and we're coming up over here, we just have to get smarter about what that gap is. So for perspective's sake, if we take a 2% increase on our expense base, which is not unheard of, right? That's supplier cost increases, that's salary increases. That's about $40 million a year for us. That means we have to get $40 million more in revenue than, because we're spending $40 million more in expenses just to keep things even. And we do that through growth, we do that through better contracting, and we do that by managing our resources. So we've done a lot of work like that this year, and it's been kind of hard and so forth, but we're not doing anything different than everybody else is doing. And this group has really done a great job in the past year to really embracing the need to change and to do that in a way that keeps our patients at the forefront of our mission.
Thank you very much. And, one of the things I've emphasized in town hall presentations and meetings with groups is that this isn't just happening to UTMB alone.
No.
This is our industry today.
It's very much
And it
so.
certainly is the case for all academic health centers, looking at how we become more effective and efficient, looking about how we increase the numbers of patients who are coming to us, change our geography, not only through organic growth, but through affiliation, different sorts of collaboration. So with that in mind, Becky, can you go a little bit more into some of the local and regional market factors that we're having to take into account as we think about how we grow and where we grow? How do we put it all together? What's most important to think about as we're thinking about the opportunities for growth and where we go?
I wish it were a simple answer. So with that said, I know there are a number of people in the room who will get an email from me or a phone call, and some of you would say, stop already, we answered this question last week, why are we talking about it again this week? And the reason is because this growth process is constant, and where we're going and what we're trying to do and where we need to be, it's a constant evaluation. And so to Dr. Callender's point, the markets, people talk quite a bit about off the island, the mainland, the League City market, the Clear Lake market. As you all may or may not know, the League City market is undergoing some extreme growth. We are very fortunate to be part of Galveston County at this time when the League City market is enjoying such a growth explosion. And the growth explosion isn't just with folks who are from the area. There are individuals moving into the area, and they're moving into the area at an unprecedented rate. Well, the positive for us in that is most of those folks don't have a healthcare provider. They don't have an established relationship with someone. So it's an opportunity for us to hook them when they get to the Galveston County market. It's an opportunity for us to evaluate how we can take care of them and what are their needs. So as we look at the different opportunities for growth, we've got to be mindful of what does that League City market look like? Texas City is another market that's enjoying significant growth. What's happening on I-45 corridor between the League City market and Texas City? I mean, again, lots of growth, lots of new homes. The Clear Lake market, as we think about where we'll be soon opening that hospital there, what does the demographic of that market look like? It's certainly more established, certainly a great payer mix when you look at the demographics of the commercial population, but also looking at the Medicare population. What's happening to that group of people? More and more folks are aging into Medicare. So we've also got to think about what are the services that we need to have to take care of all the different populations. While Cheryl mentioned we need more commercial patients. Well, what is it they want? In order to be attractive to them, we've got to have the right type of service. Dr. McCollum and Ann O'Connell have done great work with all the chairs over the last few years working on our access and our specialty care areas. We're continuing to work on our access so that we've got appointments that are delivered in a shorter time frame than what historically has been the case. But again, it's as we've grown off the island, we've had to develop an infrastructure. We've had to have more providers with more clinical output. So it's all part of managing what we do as we look forward to how we grow. It's not anything that happens overnight. I know for a lot of us, it feels like it happened from yesterday to today in terms of some of the things that we're doing and how fast we're doing it. But you all are helping us keep up. You're helping us identify what's coming as we think about the future, there will be less care will be delivered in facilities. I mean, as you think about that today, we're still working on how we grow facilities and how we increase our clinics. Well, we've also got to be ever mindful of what's happening with telemedicine. How's that going to change the way care is delivered? So we don't want to have more space than what we can ultimately manage, but at the same time, we've got to have enough space to take care of the folks that are in the different markets. Again, for those of you that are part of the Mainland activity and you've seen that growth, some have asked over the last several months, why do we have a hospital in Clear Lake and a hospital in League City? Well, there's lots of different reasons for that, but first of all, they are two very different markets. If you're from that area or you live there or you happen to know something about our marketplace, they are two different areas. But at the same time, we've had to be real thoughtful about what services do we offer at each location, because to the point that Cheryl made and also Dr. Callender, we don't want to duplicate the cost and the infrastructure to provide all services at both locations. So where we can, we are trying very thoughtfully and strategically to put those services in place that make the most sense for those specific markets. The Clear Lake Hospital already has an ICU infrastructure. Our League City Hospital expansion won't be done for probably another year at this time. So it gave us immediate access to some ICU beds that we need. All of those services, while they're delivered off the island, they ultimately help benefit what happens here on the island. So some people laugh, but I oftentimes refer to the island hospital, the Jenny, as how we need to be mindful of feeding the beast. But we need to make sure that what we're doing off the island is continuing to grow and develop our programs and our services so that we have the referrals we need to send back to the island so that we can further take care of the population via the quaternary and tertiary services that are needed, and also to help our education programs.
Thank you very much. And that brings up an important point too. You know, people, particularly those who live here in Galveston, more and more are worried that we're moving away from the island because they see this tremendous amount of activity on the mainland. In Clear Lake, most recent example, the growth in League City, not only of the hospital, but the clinics in the neighborhoods in League City and the surrounding communities. They hear about us growing in Angleton, Danbury, and so their concern is that there's a secret plot to move off the island. And when that comes up in conversations with me, I remind them that over just about the past 8 or 9 years, we've invested $2.2 billion in facilities on the island alone. It is our hub. It is our home. And when we're talking about these strategies, Becky just mentioned this, Galveston is the home not only of our research and education programs, even though elements of those are also distributed off the island, but it is the home of our highest level of care. And that will continue to be the case. We've done a lot of market studies looking at how patients move. They really don't want to travel very far to see a primary care physician or even a specialist. They want those offices, if they have to go somewhere, to be within a 5 to 10 minute drive from either where they live or where they work. And so a lot of our strategy on the mainland is to place primary care locations and specialty clinic locations within a 5 to 10 minute drive of where people live or work. Now, the hospitals are there to provide the community plus level of care that's about a 10 to 15 minute drive from their homes or places of work, because again, the market surveys tell us that's about how far they will go. We've tested that a little bit because some of our patients have not been able to be admitted to the League City Hospital, and we've offered them a transfer to Galveston Island. They won't come here. Instead, they go to Clear Lake Regional or St. John's or one of the other mainland hospitals. So if you think about that, all the more reason for us to have an adequate number of inpatient beds up on the mainland to provide care for our patients who really won't come to the island unless they need a higher level of care. Now, we know that they're willing to drive 30 minutes or more if they need a high level of specialty care, and so that's why having our hub on Galveston Island with our highest level of specialty services here will continue to work into the future. We're not moving away from Galveston Island. It is our home, but it's very important for all the reasons that we're articulating to be well represented on the mainland, and in particular, have our clinical inpatient and outpatient facilities within a reasonable distance of our patients. So that's the location strategy. Becky, before I ask Dr. Vicente to talk a little bit about physician supply and how we deal with that, can you talk a little bit too about populations? There have been some concerns expressed that we're abandoning Medicaid patients in pursuit of commercial patients, and we know that's not true, but can you talk about sort of the differences in perspective of those patient populations, and in particular, talk about the different level of needs for those two populations and how we're trying to deal with that?
So most of you, or many of you, may have had the opportunity to take care of your parents or grandparents as they age, and you recognize that the Medicare patient often has a different type of need. They have appointments that they like to arrange at a certain time of the day. They have transportation needs, people helping them get to and from their appointments. The same is true for the commercial population. Oftentimes, they like to access services after hours on Saturdays and Sundays. Again, more convenient, urgent type care. Then there's the Medicaid population. They too have a set of services and needs that they have relative to accessing their health care. Oftentimes it's transportation services, oftentimes it's translation services. It might be as simple as follow-up services, access to medications, how they access social services. So we have, over the last probably almost a year now, been evaluating how do we think about the care that we deliver and where we deliver the care to these different populations. As Cheryl mentioned, we think about growing our commercial business and also our Medicare business. If you think about all the seniors in the market and how they will continue to need more health care as more people age into that senior market. Because so few people take Medicaid in the market, we are fortunate that we take Medicaid and we continue to take care of those patients, and we will continue to take care of the Medicaid patients. We want to make sure that we have been thoughtful about how we deliver the services that they need. Some people refer to them as wraparound services, these social services, transportation, translation services, making sure that we have identified within our clinic structure ways and opportunities for that Medicaid population to access those services. But at the same time, understanding we may not deliver care at all of our locations to all of our populations because of how that group of folks accesses their care. We need to make sure that we've got access for all of our populations and financial classes across all of the region. And so because so few people take Medicaid, and you are seeing now many providers don't take Medicare, we do take all of those. And so where we have patient slots available, they fill up very quickly with Medicaid patients and Medicare patients, and we oftentimes don't have access for our commercial population in areas where our commercial population lives. So we are working right now at how we think about redesigning access for our different patient populations. So again, we are not in any way limiting care for any of those populations, but we're actually trying to be more thoughtful about how we deliver the care so that everyone has access, and not only access, but we've also thought about how we meet the social services needs of that population.
A great point. Thank you very much. Coming back to what Ms. Sadro was describing earlier with value-based reimbursement, it really is driven by outcomes with patients. And the payment systems don't distinguish on the basis of socioeconomic status or the social outcomes associated with those. We now know that there are a number of things that impact health other than the care we deliver to patients, the advice we deliver to patients, the ability to get to and from an appointment, not living in a food desert or having an adequate supply of healthy food is huge. Social or living condition themselves have a big impact on health. Did any of you see the article in the Houston Chronicle early last week about the University of Texas system study that was led by the people at Southwestern that looked at zip codes around the state? Any of you see that? Some of you did. And so there are huge disparities in health outcomes based on the zip codes where people live. And one zip code can be right next to another one, and one of those zip codes has terrible health outcomes and the other has great. And the geographic distances may only be a few miles. So we're trying to think about those things too, think about the different populations of patients, where they live, all of the things that patients want, and all of the things that they need to help them achieve the best health outcomes. So it's a very complex area for study. A lot of our growth strategy really depends on how we sort through those issues. And then as an academic institution, we have a huge role to play in terms of leveling the playing field across different populations in terms of generating the best outcomes. So again, value-based reimbursement, our success in terms of delivery of healthcare and being paid for it, depends on us being able to optimize health outcomes no matter the population. For us, in dealing with the disparate populations that we serve, we're having to develop individualized approaches based on geographic locations and socioeconomic status, in addition to wants and desires of patients. And so, again, a complex set of variables, but very important for us to consider those as we go forward if we're going to be successful and execute our academic responsibility. So, all right, let me shift gears. Now, we've done a pretty good job recruiting physicians and faculty members and healthcare workers as we've been at a steady rate of growth. But we've been talking about accelerating that, about greater geographic coverage. Chairs have done a great job recruiting, but what do our academic departments do now? What do we do as an institution in making sure that we have an adequate number of not only physicians, but all types of providers, Vicente, as we go forward? What are we doing now, and what are we thinking about doing as we go forward?
Well, clearly, we continue to grow the faculty group practice as we have, and as time and resources permit. And I bring that up because I think oftentimes the cost of ramping up a new faculty hire goes underappreciated. In some cases, it could cost us about $1 million to deploy a new faculty member, a highly specialized, high-salaried individual to come in and support the work that we're trying to do on the island. So despite the fact that we will want to continue to do this, as it's critical to what we do, I think we also need to embrace the fact that it's not something that we can do so without any limit and indefinitely. And how that matters is because if we now look at the timeline of some of these opportunities we've jumped into, such as the Clear Lake Hospital, such as the continuing development of our League City facilities, and in particular the former because of the timeline at which it came up, we don't really have a deep bench from where we can extract individuals and deploy them in a way that we could cover such a large facility with this rapidity and need. So it's made us reevaluate a bit, how is it that we are going to staff this and likely all our other facilities going forward. And that is really tapping into the community physician network that already exists. We've done some of this work at UTMB, in particular through our Angleton experience, but I think it's fair to say that that has been at a relatively small scale in a market that is relatively, I guess, lower key and a little bit less visible. We're now entering a what likely would be considered the most visible market in the corridor between Houston and Galveston, with a medical community and establishment that has been there for many years, very savvy, and frankly not always very supportive of UTMB. There's been a tremendous amount of antagonistic activity over years. You know, they have at times identified us and referred to us in a very adversarial, protective way. So we frankly have had to reimagine how we engage them because we need to be practical. And we've done that with great success. We've reached out, we've asked the questions, we've sat down to try to incorporate what are the important areas that are relevant to them, that are relevant to how they deliver care to their patients. And there's a lot that we have learned. We have any number of resources, not only from subspecialty support, but some of the facilities that we're rolling out locally. And frankly, as they learn the high-end facilities we have here on the island, all of these are avenues that help enhance the care that they can provide to their patients. And that's been something that has been very interesting to them and very useful. Going forward, there's a different aspect to this that I think, again, doesn't often get discussed. But as an academic organization, if we could order the kind of patient, the kind of care that we'd want to deliver, we would love to have the highest complexity, most difficult kind of care that we could provide. And the reason for that is many. It supports education, it supports research initiatives and innovation, and it really, frankly, kind of maximally utilizes the skill set that the highly specialized set of doctors and practitioners that we deploy here have. That patient oftentimes comes to an organization through physician referral, as opposed to more lower complexity to mid-complexity care, which, as is the case in Texas, oftentimes is very patient-driven. And they'll go on the internet and they'll learn where the facility is. They'll look for the convenience of the 5-minute, 10-minute, reach out to a facility that has great service and is very aesthetically pleasing and delivers what they need. But when we're starting to think about transplant care, when we think about high-end neurosurgical care, as may be the case in aneurysm disease, which is really an high complexity work associated with stroke, and so on and so forth, those patients generally present to other doctors who then, in taking care of the patient and trying to diagnose the underlying issue, understand the level of complexity, and oftentimes from the community setting, they'll transfer to a high-end, high-complexity care facility. In this market, it has traditionally been the medical center. Our presence in the Clear Lake and Lake City market has given us great exposure to showcase what we can do here in UTMB, which I would argue that is, if not all the way the same, it is nearly all the way the same as to the kind of care that is delivered in the medical center. And I think the comfort level is increasing. So we've seen this tide change. And all of this occurs, basically, it's really all built on those relationships. It's really built on that interaction that we have with those doctors, bringing them closer and further inside, as opposed to, further away and putting barriers. So there's just a lot of things we're doing to change this. And frankly, a lot of it is teaching us things that I think are going to make our life as full-time employees as the faculty who practice here a lot better.
Very good, thank you. Yeah, approaching the community physicians as partners, very important to us as we go forward. The other thing you did mention, but I know is important to a lot of our educators, is a number of those community physicians have expressed a desire to be involved with our students. And so again, opens an opportunity for us to expand the clinical placement sites to support our existing educational programs and their potential growth in the future. So a lot of opportunities associated with working with the community physicians. Also on the research side, thinking about clinical research, the opportunity to engage community physicians in identifying patients, perhaps even enrolling some patients in clinical protocols is also an opportunity for us. So in general, we're very excited about the opportunity to work with community physicians to bring Our approach as innovators, if you will, as academicians with their approach of providing the best possible care for their patients, working together to advance both. So thank you for those points. One of the things that's really important in all of this is having really good information, whether it's from the standpoint of looking at outcomes of practices, beginning to segregate that based on which population a patient belongs to, thinking about how patients flow between different provider sites and different providers. Having really good information and information systems is critical. Cheryl, we're investing a lot in terms of information systems and analytical tool sets. It's important for growth. Will we continue that investment? How are you thinking about that as we go forward, and how does it tie to the growth strategy?
Sure. We have spent a good bit. I would say on average, Todd, correct me if I get this wrong, but I think it's about $25 million a year just to keep up with systems and changes, especially in the EMR side of the world and in a lot of our research type expenditures as well. And that being said, so we did, as most of you know, implement what we now finally call UTMB Discover about 2.5 years ago, I think it was. That came out of a need for this organization to really have a place where data could be stored, extracted, translated, and then put into some sort of format that could be used. We're up to probably, we call them applications, we're up probably a little bit north of 20 applications in 2 years. Dr. Sharma and his group are doing a lot around the high-value provider organizations. There's, I think, 6 apps already that you're looking at or have developed there. There are length of stay applications where you can go in and take a look at why a particular patient is maybe staying longer than maybe the geometric length of stay says they should stay. So is it based on a unit? Is it based on their age? Is it based on their comorbidities? What's happening with that patient that causes them to need to be here longer than possibly they should be? So a lot of different things you can do with that application. Just the other day, Dr. Patel shared the application around surgical site infections, and he's got just a world of data there that can tell us where we might be seeing those infections increase, what type of procedure we're looking at that might have the largest infections. He can look and help the physicians that might be seeing greater amounts of infection and why maybe that's happening and how can we help to reduce that number. And then Dr. I forget to draw on his name, Macharsky. Thank you. Beg your pardon. Is actually looking at patient sat and the application around patient satisfaction and how Donna and her team can use data from that in terms of patient sat on certain units. Do patients like our food, I guess, those types of things as well, and how to use that data to drill down and improve our scores around patient satisfaction. And probably one that I've been a little bit closer with, and certainly Katrina's been very close to, centers around how we are reimbursed with our DSRIP funds. So if you don't know, DSRIP changed the methodology for reimbursing us quite a bit in the last year. So we used to get reimbursed by taking care of a certain project. Now we get reimbursed by meeting certain outcomes for patients. And in order to know how we are impacting our patients, so think of things like, have they had mammograms? Have they had their flu shots? If they're diabetic, are they taking their correct medications? In order to make sure that we are providing the care that they've challenged us to provide, we need that information by patient. So before, we might have to go through every single medical record by hand. Think about that. And say, yes, this patient had this immunization, they're taking this drug, so forth. With the data that we have in UTMB Discover, we can actually now extract that data digitally, and it's made it much more efficient. And it's allowed us to increase the amount of reimbursement that we've gotten. So there is a world of data out there. Ask the question, and we can probably find a way to get you the answer with a lot of detail that will help you figure out how to solve the problem you're trying to solve. So it's been a very worthwhile investment.
So important for us as we think about how we reach out to communities,
Absolutely.
to patients, look at their health outcomes, what we're doing to improve those, and then make suggestions about specific things that we can do for specific patients. The other thing we know is that the payers, government as well as the commercial payers, are already using information like this. They have big analytical systems, and they're basically evaluating us, are profiling us on the basis of our behaviors and the outcomes that they generate. And so we'd like to have better information than they do. So again, we can remain attractive to different payers as providing effective and efficient care. So the information systems that we're investing in allow us to do that. And you can even think a little bit about the telehealth connections. Becky mentioned those previously. So when we get our analytical tool sets to a certain level, we will understand, most likely understand, what are the things, what are the differences in behavior between a Medicaid patient with type 2 diabetes and a commercially insured patient with type 2 diabetes? Are there significant drivers that are different between the two? And then understanding what those are, basically send a prompt, a text message, if you will, or even in some cases for the higher risk patients, a video connection through a smartphone that is a reminder or a prompt to have them consider that behavior or behaving differently so that they improve their chance of better blood sugar control. So again, these are the things that we're moving toward. Healthcare will be very different in the future. We want to be able to broadly engage all types of patients over large geographies to have a positive impact on their behaviors and their health outcomes over the course of time. But let me come back to the large geography. We've talked about organic growth, physician supply, some of the things that are happening out there in our part of Houston. How much will collaboration play a role in terms of our growth strategies going forward? Becky, you want to start with that one? Cheryl, we'll come back to you too.
Sure. I think we have to recognize what our strengths are and what we're good at in taking care of patients, and also look at what other organizations bring to the conversation in terms of how they take care of patients and how we can potentially leverage their strengths and our strengths to benefit the patients as a whole. So very specifically, the UT system Board of Regents has asked us to work more directly with UT institutions, and so we have a MD Anderson collaboration that many of you are familiar with, and while they have a building on our campus and they are seeing patients in that building, and we also have a clinic in that building, we will continue to look for more and more ways to collaborate with MD Anderson to deliver care to MD Anderson patients and UTMB patients. I don't think it stops there. I think we need to look at how we can work with UT Houston and leveraging the care that they already deliver in the Clear Lake market. What can we do potentially at the Clear Lake campus to deliver care to UTMB patients and potentially UT Houston patients? As we think about post-acute care, UTMB doesn't operate a home health agency. We don't have a post-acute long-term care facility. There will be partnerships where we can collaborate more directly with organizations in the community that already deliver those services. They already have expertise there. So we will need to be looking for partnering and collaborating opportunities to work more specifically with organizations that have expertise in other areas from UTMB to further care for our patients, which hopefully there will be opportunities for us to share patients in this process as we think about it going forward. But again, the reimbursement is decreasing, and we need to look for the most efficient ways to care for the patients. By leveraging organizations' expertise and experience, we don't have to build it ourselves. So again, there's opportunity significantly for everyone to look at how we better integrate and collaborate going forward.
Thank you, Becky. So Cheryl, Becky's talking really about vertical integration. That was one of the concepts she mentioned. Can you elaborate on that? What might that look like in terms of us working with other organizations and thinking about the continuum of care? And I know that you all were doing this when you were with CHI. And so can you sort of talk a little bit about some examples of maybe some things you did and some things that we might be thinking about as we go forward?
Sure. I'll take the example I think that Becky mentioned in terms of the outpatient care that's provided to our patients or the post-acute care that's provided to our patients. So long-term acute care facilities, pretty hard to find those that'll take our patients, right, Donna? So pretty hard to find those. We did quite a bit of work in the past and something probably that's very appealing to us in the future, but we did a lot of joint venture type relationships with those organizations so that we could get the patients out of the hospital, not to have them out of the hospital, but to have them at a level of care that was much higher, and we could provide their, for their wellness much easier. Difficult relationships sometimes to get into, but we certainly found them to be advantageous. And then we could get patients in that we could care for a little bit more quickly. Another one of those relationships is simply just the care that we provide for patients in rehabilitation. So when we have an orthopedic patient that needs to get out and needs some care to get back on their feet, how do we actually then get together and have an agreement with someone to take that patient on a very quick basis, because we don't always know when that patient's going to need to be discharged, and we need to be able to have access like that. A lot of the other things, I'm losing my microphone, sorry. A lot of the other things that we did were actually looking at ambulatory surgery centers. Now, sometimes that's a hard thing for physicians to look at in terms of being afraid of losing their surgical procedures. But we do have the ability to partner with external groups. I'm not saying we're in the middle of doing that, but there's an ability to partner with external groups that know how to do this very quickly and very efficiently. Maybe we have some interest in that group if that's allowed by the regents. But there's just many, many ways that we can help our patient population enhance the care that they have or help them get out of the hospital a little bit earlier. They're not exactly the safest places. You can get kind of sick in a hospital. No, Donna, yours are great. But there are many, many different things, and we're going to have to continue to find those things. One of the things that Ascension Health does extremely well, and Dr. Callender has begun this process here over the last several years, is look to the venture capital market. So there's a lot of folks out there. This is becoming a very big trend. There are a lot of folks out there that have a lot of money that they want to invest, and they want to be able to help us provide better healthcare services. And that may be finding a product to develop, that may be setting up an ambulatory surgery center, it may be a lot of different things. But that capital is out there, and to the extent, again, that the regents allow us to do that, that's a venue that we need to continue to explore. We've got to continue to look for different ways to take care of our patient population. I wish it were kind of like, Mayberry, but Mayberry was after I was born, too. No,
Okay.
Mayberry was before. I'm supposed to say it that way, but I was born. But there's just many different things that we need to continue to look at. Our patients, I've said this before, my daughter wants to be able to look at her phone and say, my throat is sore, doctor. Oh, and I went to the pharmacy and bought this little kit. I swabbed my throat. Here, let me rub it on this screen. Can you look at that and tell me if I have strep throat? I mean, that's what those young folks are going to want to see. And that doctor can say, yes, Carson, it looks like you have strep throat. Let me call in the prescription. And oh, by the way, maybe that drone will deliver that prescription to your house while you're sitting in your comfy pants, as the commercial goes. So we really have to continue to look at different ways to make our health care very affordable for our patients, but what they want and in the manner that they want it.
Absolutely.
Did I answer your question?
Yes, ma'am. Thank you very much. And this whole concept of leveraging resources.
Yes.
All of these things that we want to have happen or need to have happen in support of our mission work, and we have a finite amount of resources to invest. So the other thing collaboration offers is the opportunity to leverage existing resources or those coming from another provider organization or another support organization, so that together we can do more without having to create redundancy and use up all of our existing finite resources. So,
Absolutely.
thank you. Okay, last question for Vicente, and then we'll open it up to the audience. So collaboration, one of the concerns, particularly expressed by our providers here, is that we're giving our patients away. When we're collaborating, they're going to see these other physicians, and we're going to lose them. Is that happening with MD Anderson, and how much of a risk is that?
I think the short of it is that there is a bit of a risk there, but I think I would rephrase it or relook at it more as a bit of an investment. I mean, we looked at the idea that if we're engaging in productive relationships, if we're engaging in productive collaborations, if we can indeed deliver something larger and more complete and really at a higher level of a product, then we will ultimately gain more. That particularly holds true in the context of the growth environment we live in. Sometimes people live in communities that are not changing very much or maybe shrinking, and then there is worries about the smaller pie or a piece of the pie that will not change. Well, that really is not true here. This is such a dynamically growing environment. There truly is opportunity for everybody. And I think that for as much as a patient flow may go a bit differently in the short term, first of all, we are aware of it. And to all these analytics and all the information that we have, it is certainly not escaping us that this is happening, which is important because you do need to keep an eye on that aspect of the matter. But we do see that there is a reverse, movement of patients as well. And we hope that that'll mature across any number of different fronts. The MD Anderson collaboration is an important one. We have engagements that are really starting to have the difficult conversations. Can we really come in together and truly view a pool of new patients as truly a combined pool of new patients? Can we figure out a way of, directing patients to one side or the other, or maybe in a short-term future to one same place where maybe all of us come to work together? A lot more talk and a lot more conversation there. We can go to the community in a similar way. I mean, trust me, for as much as we may be worried that our patients are going to go somewhere else, the community practitioner is terrified that their patients are going to go somewhere else. And the scale is quite different there. So I think this is something that is real. I think we've had success at openly discussing the issue. We keep a close eye on it. We really try to come up with solutions that can deliver a win-win on both sides. And they're available and they're possible, in particular in this environment we're living in.
So we clearly understand that, and as we go forward, we develop these collaborations. We're trying to upfront establish the aims and that win-win situation and what that looks like for each of the parties, and let that guide development of the arrangement. All right, so there you have it. So the things driving growth, everything from more clinical placement sites needed to support our education programs, more sites to support our research programs, the need to produce more revenue in support of education and research over the course of time, the need to grow our patient population so that we have a seat at the table as we move from fee-for-service reimbursement to value-based reimbursement. And then what I think is most important over the course of time, the ability to pursue our academic goal to improve health. looking more broadly at the populations that comprise communities across the greater Houston area, what drives disparities in outcomes, applying our great analytical tool sets, working with community physicians to level the playing field and optimize health for everybody, no matter which population they belong to. So all of those things are at play. Again, those are all playing a contributing role in driving our thoughts about growth and where we go from here. Thank you for coming today to hear about some of those. We're more than happy to try to address any questions that you have. Wow, we blew you away with a cogent argument for growth. All right, so thank you all for being here. Thank you for braving the cold. Have a great rest of the week. We look forward to seeing you back to talk about evolution or revolution in healthcare. Thank you very much.
UTMB Health, working together to work wonders.